And we are back with another episode of our Forefront of Future Frontiers, the medical webinar series, which is being organized by the Scientific Society of Arupadavidu Medical College, which is a constituent college of Vinayaka Missions Research Foundation. And this is series, and we are now in episode 93 and series 14. The theme of this series is priority areas in public health. So we have explored various priority areas in public health. Last week we spoke about road traffic accident. Some time back we have spoken about the delivery of healthcare services in the primary healthcare level. We also explored different aspects of uh, communicable and non-communicable diseases in this particular series. So today we have another area which I think is one of the emerging areas or established emerging areas in prior public health, and but not very often talked about. That is about drug abuse, use and abuse of drugs in the society. And we have with us Dr. Suresh Kumar, who is a renowned expert in the field of psychiatry. He's also a consultant psychiatry associated with Psymed Hospital in Chennai. He is going to deliver the talk today on substance use and addiction. And before we proceed, I would request our Dean, Professor P.F. Kotu, to welcome the gathering.
Yeah, thank you, Professor Mahalakshmi. Today's speaker, Dr. Suresh Kumar, and my colleagues, Dr. Vishnu Bhatt and Dr. Mahalakshmi and Vijay Lakshmi, and all esteemed participants. This Triple F platform now is having a 93rd episode, progressing towards the 100th or the centenary episode shortly. And our speaker will be happy to learn that we have established quite a credibility by offering uninterrupted webinars for the past almost 2 years, more than 2 years. We started to drive away the claustrophobia during the onset of the COVID pandemic, and today it has earned such a good credibility across the country, rather across the globe. And Professor Mahalakshmi already hosted various topics. This platform has been shared by eminent teachers, academicians, researchers, scientists, and experts in the field. We have one more person today, of course, Dr. Suresh Kumar, who is an expert in his own field of psychiatry and this burning issue. I said this drug use or an abuse or a overuse or addiction is a not only a problem across the globe, it's a global burden of. And other day, we were telling in India also have quite a good sizable number of adults who are the victims of this, nearing to 18, 20 lakhs. It's quite disheartening to know that. And even though this lot of research is coming in nowadays, this problem I think is dates back to thousands of years back in the sense the opioid. Opioid has been there for so many uh, millennia. And it is updating back, and even in the ancient Greek history, ancient there, the opioid usage by the people as recorded, and only in the time we have added so many other drugs, including some of the this anesthetic drugs also I have heard, the ketamine and other stimulant drugs, amphetamine, and this alcohol, of course, has been over there even from the age-old days. Wine, during the days of this, what do you call this? The, the ancient mythology says usage of the wine by our gods and goddesses earlier. Even from that time onwards, it has been over there. Sorry? Yeah. So
Go ahead,
this problem is now it has realized that it is hazardous and harmful to the community and causing various types of burden to the country, to the family, to the community, financial burden. The financial burden caused by addict husband, to the family. We all know children suffer, wife suffers, relatives suffer in all possible ways. Such a one burning problem. Today we have Dr. Suresh Kumar who will be sharing his experience, and that has come under the purview of the psychiatry. Many of the we see in various places, de-addiction centers, etc. So that has come under the purview of psychiatry, and I take this opportunity of welcoming him on behalf of our management, Honorable Chancellor or Madam Chancellor, members of the Board of Management, University at large. Certainly, I'm sure the next 40 minutes or so will be quite interesting and interactive and beneficial to all of the participants who have logged in now today. With these few words, I think I will hand over to Professor Mahalakshmi, to
Yeah.
resource person.
Thank you, sir. Also, I take great privilege in introducing the speaker for today, Dr. M. Suresh Kumar. Sir is currently the Director and Consultant Psychiatry of Psymed Hospital in Chennai. He is also the Head of Global Research and Development in a program called Cities Rise, that is the global platform to enhance mental health among youth in Newark, USA. He is also an advisor to the Trust Sanmati, which is an NGO to promote mental health among populations. He was formerly working with the Ramachandra Medical College as adjunct professor. And before that, sir had been, he had done his MBBS, DPM, MD, all from Madras University. And he has done his MPH in Masters in Public Health from John Hopkins. And that is, if I keep reading the CV, today we will listen only to the CV and not to this thing. And his relevance to this current topic is he's actually a Humphrey Fellow in substance use from John Hopkins. He has done extensive work in the field of mental health and substance abuse disorders as a teacher, trainer, researcher, and the international consultants. He has worked with various international organizations in this particular regard and across various countries like Afghanistan, Bangladesh, Bhutan, China, etc. And many of his papers are related to this particular thing. And he is also in the board for editorial board for International Journal on Drug Policy. So we can't find a more appropriate speaker to come and talk to us about substance abuse and what it actually, how it affects the society and the population, especially for our young audience here today and many of us who are novices in this particular subject. The stage is yours, Dr. Satish. You can, Dr. Suresh, you can talk. I'm sorry. I'll make you the host presenter, sir. You'll be able to share your slides.
I'm unable to do that right now. I don't know why. Have you given me the sharing?
Yes, sir. I have given you, sir. Yeah, now I can see, sir.
Okay. At the outset, let me thank you profusely, Madam Mahalakshmi, for inviting me to be here. I consider it as a privilege. I want to thank the Dean of AVMC and the rest of the faculty for having me here. Today, what I'll be focusing, I'm going to give you a broad overview on substance use and addiction. In doing so, I have 4 points to discuss. First, I'll talk about what we understand by substances, how do we classify them, what are the various terms we use in this. Second, more importantly, we need to understand how substance dependence develops over a period of time in an individual. Third, I would like to take a very public health approach and look at and say, what are the various harms related to substance use and dependence? And finally, I'll talk about the treatment strategies with a lot of focus on harm reduction. First, let me walk you through the substances. I think we use the two words interchangeably, drug and substance. The word drug was very confusing. That's what we prescribe in medical practice. So obviously, we abandon the term drug and then introduce a new term called substance when it comes to psychoactive substances, mind-altering substances. So when we talk about drug usage, we mean psychoactive substance usage. So we really want to understand the classification of substances, I think alcohol is the most important one. I want to put it separately, even though some of them would like to consider it as a depressant. I want to consider it separately because it's a huge public health burden, and all alcoholic beverages are the same. It's a question of, how much of alcohol they contain. That's more important than declaring any beverage as a moderate drink. Cannabis is the next important one worldwide, known by different names in different parts of the world. Westerners will call it marijuana. India would call it the bhang, ganja, charas, ash, depending on the potency. Opioids, as our dean pointed out, has been there for quite a while historically. And what is really bothering us is the synthetic preparations and semi-synthetic preparations and pharmaceutical preparations of opioids. This is what is becoming a huge public health crisis, not only in this country, but in the rest of the world. Depressants, many of them are very useful medically. Benzodiazepines, primarily used as anti-anxiety agents, can also be abused. Stimulants, I think the most notable stimulant we all know of is nicotine. Nicotine is the most well-known stimulant, followed by simple things like betel nut, caffeine, which all of us drink every day, and of course, very hardcore ones like cocaine, amphetamine type stimulants. And I think
rough
there are
teaching schedule.
inhalants.
And Wednesday the joint first.
Okay. Inhalants are also very important, particularly when it comes to children and adolescents. And this is largely used by street children. Glue, petrol sniffing, cleaning fluid sniffing, they're all very common among young adolescents. And of course, Dean mentioned about the dissociative anesthetics, which are becoming extremely popular with younger people these days, with ketamine. And new psychoactive substances emerging all the time in the world. That's our serious concern in many parts of the world. Synthetic cannabis, synthetic stimulants, and hallucinogens, they are more powerful than the original ones. So just look at some of the things. This is the opium one that everybody knows about, the poppy. It's a beautiful flower and the poppy plant, and from there the opium is obtained. And the most important one is the heroin, which is a diacetyl morphine, which is actually extremely addictive. And of course, we have the amphetamine type stimulants, which are becoming a big threat globally, not just globally, but also in India. 10 years ago, nobody would have heard of a amphetamine type stimulant abuse in a city like Chennai or Pondicherry. Today, I think this is one of the important drugs that's emerging as a concerned drug in many parts of the country, including in Tamil Nadu and Pondicherry and the rest of the country. Cannabis has always been used, misused, abused by people across the world, including in India. Hallucinogens like LSD, originally synthesized as a mind-altering drug, has been really, really addictive drug. So I'm just going to be quickly moving on to the various terminologies that we often use and get confused about. So I want to provide some clarity to the terms that we often use. What is one term that is used is misuse. Misuse just means we are giving a medication or taking a medication for non-medical use. Benzodiazepines can be prescribed by a practitioner to reduce anxiety. But if somebody is taking it not for a medical purpose, for a non-medical purpose, it can be called as a misuse. Also, a socially accepted drug, like say alcohol, when somebody is using the same drug in a way that is not socially acceptable, that is also misuse. Another term that is often used is abuse. And abuse is very confusing because people use it on different reasons. Non-medical purpose use also can be called as abuse. When some drug or substance is causing harm to individual or to others, that is also called abuse. And illegal substance use is also called as abuse. So we suddenly go through misuse and abuse, we get very confused. So WHO thought we will not promote these terms misuse and abuse. We'll take it away from the dictionary. Let's use a public health approach and bring in terminologies that can be unified applied everywhere. One of the things that is often used, term that is often used is a hazardous use. What is hazardous use? When somebody exceeds a quantity that is actually permitted, a quantity that can produce harm to the individual potentially, is called as a hazardous use. Typically, you can refer to alcohol and say alcohol is a socially accepted recreational drug. We define alcohol units as standard drinks. Somebody has a 6 drinks, standard drinks. You know for sure that's a very hazardous level of drinking, even on one occasion. So somebody in a party drinks about 6 drinks, 6 standard drinks. Obviously, this means this person has a hazardous use because it can potentially do harm to this individual. The second term that's very important is the harmful use. Harmful use is where a specific substance has produced an identifiable, describable harm, either a mental harm or a physical harm, or it has resulted in an impaired judgment, resulting in a road accident, for example, or it created an abnormal behavior, a bar fight, for example, or created an interpersonal relationship within the family, causing a familial conflict. So this is called as harmful use, where there is a definitive harm done either physically, mentally, financially, or familially, or socially. And the third word WHO ICD-11 has accepted is dependence. Dependence are separated into physical dependence and psychological dependence, because certain drugs can produce large amount of physical dependence and certain drugs do not produce so much of a physical dependence. Classical example would be, a lot of young people will debate and tell you, I am taking cannabis, I am not an addict because I do not have any physical dependence on it. But unfortunately, they have psychological dependence on this drug like cannabis. They may not have physical dependence. A drug like alcohol, a drug like heroin will produce significant physical dependence in addition to psychological dependence. So these two are separated. What is the definition of physical dependence? To say physical dependence, the person should have 2 important phenomena. One, you should have a withdrawal syndrome. If I stop taking a particular substance, I develop manifestations on discontinuation. That's called withdrawal syndrome. Presence of a withdrawal syndrome indicates the person is physically dependent on it. The second aspect is tolerance. In pharmacology, all of us learned about the phenomena of tolerance, increasing the quantity of the drug in order to get the same effect. So a combination of withdrawal syndrome and an abstinence syndrome along with tolerance is referred to as physical dependence. Then what is psychological dependence? Psychological dependence is characterized by 5 criteria. One is the person has an impaired control or compulsion to use the drug. He'll go to the bar saying that I want to have a drink. But the moment he has a drink, he gets drunk because he continuously drinks. He has lost control over the termination of drinking. Loss of control over both onset and termination of drinking or any substance is referred to as impaired control. I am unable to control the quantity of alcohol that I consume or substance that I consume or time that I can consume. The second thing is the substance alters the mood. These are individuals who go to a bar, have alcohol, start crying or start to become boisterous because the mood gets altered. Second, their third phenomena is a phenomena of craving. Craving is a very significant phenomena in addictive behaviors. And craving underlies the addictive behavior. So this is a mental part as well as a behavioral part. I am mentally preoccupied and I'm also searching to get the substance. So the craving has both mental and behavioral component associated with that. Then there is the psychological symptoms. Some people might stop, may not have physical withdrawal symptoms, but may have significant psychological withdrawal symptoms. And then there is this non-physiological attachment where they say, I am feeling very bored or negative or depressed or anxious. I require the drug. So I am here using a drug either for euphoria or for relief from problems. And finally, the word addiction, even though it's not been used by WHO, people like me who have been working in the field for 4 decades don't want to leave the word like addiction. We are quite addicted to this word. So American Society of Addiction Medicine defines addiction in a very different way. They now medicalize addiction. They call it as a primary chronic disease of the brain. So addiction is indeed now considered as a brain disorder, a disorder that involves the circuits, brain circuits of reward, reinforcement, motivation, memory, and other related circuits. Dysfunction in these neural circuits, they lead to the characteristic manifestations, what I've been describing so far, the biological, psychological, social, and spiritual manifestations of addictive behavior. This is reflected in the individual pursuing the drug either for reward, which is for euphoria, or for relief from painful symptoms. So the person is seeking it either for reward or for relief. So basically, addiction is now conceived as a brain circuitry disturbance leading to characteristic manifestations. There are many substance use related disorders that include intoxication, withdrawal, substance dependence itself, and substance induced medical and psychiatric disorders. And our dean was telling, in India, the number one problem, apart from tobacco, is alcohol. Alcohol use is so huge. There are 16 crore users, adult users in India. 5.7 crore people are problem users, and 2.9 crore people are dependent on alcohol. This is a huge problem. I don't really think only mental health professionals can deal with a huge problem like this. This is everybody who is a medical professional, his or her duty to look after the problem of alcohol use in this country. You look at a drug like opioid use, there again, significant number of people are using opioids. 2.3 crore people are using opioid, of which 28 lakh people are dependent on opioids. So the numbers are huge with regard to substance use. And I just want to go quickly to what we know about the dependence development. How does somebody become dependent? You need to understand there are several risk factors that contribute to substance dependence. It could be because of the genes. If I have a family history of alcoholism or substance dependence, I'm more likely to become a substance dependent individual. So the warning and a public health message should be, if anybody in your family is dependent on any substance, you are the person who should not be touching any substances because you are more likely to transit into dependence. The second important factor is also relating to, the environmental factor. People who come from disadvantaged settings, broken homes, bad peer influences, bad social norms are more likely to develop addictive behavior. That's one of the reasons why it's extremely common in certain communities, not because they are prone for it, the environment is conducive for them to develop this addictive behavior. And these two things, genes and environment, interact together. The gene-environment interaction leads to substance use. And I think it's also to do with the cost of the drug, the availability of the drug. 30 years ago, certain drugs were not available. People are not addicted to those drugs. These drugs are available today. That's why people are addicted to it. And then finally, they all influence the brain mechanisms. And only because the brain mechanisms and the circuits are involved and people develop a substance use disorder or a substance dependence. What is concerning is, this is the work I did in 2004. In 2004, I was looking at the countries in various South Asian countries. Even then, the mean age of alcohol use was below 18 and cannabis was below 18. And opium and heroin was also around 18. So, but then, what does the science tell? What's the science behind addiction? We all know the earlier the exposure to any substance, the more likely that the person is going to become dependent on the substance. For example, if somebody is going to be exposed to alcohol or substances by the age of 10, 12, 13, 14, his brain is still not myelinated well. It's not a mature brain. A mature brain exposed to substances is more likely to develop dependence later on. So it's very, very important public health message. The second public health message I want to tell is, those who are very young should never touch substances. So you have to delay the onset of substance use beyond the age of 20 years. So those with family history do not touch substances. Those below the age of 20, when your brain is not completely myelinated, do not take to substances. So there is also progression associated with substance use, which gives us an opportunity to intervene. Everybody experiments with drug use, then become a recreational user. Till then they call themselves as social users. Then it becomes a regular use. And finally, it becomes a compulsive use. To become a compulsive user or an addict or a dependent is hard work. Nobody becomes a graduate overnight. It takes over a period of time. Unfortunately, the transitions are very smooth and people don't even realize they are transiting from one phase to the other. And I think what is important is as one continues to use any substance. For example, if I'm continuing to expose myself with tobacco and alcohol, there is a pathological shift in my brain hedonic set point. Normally, there is a reward system in the brain which wants to be excited by any pleasurable things. I want to be excited by food, sex, and adventure. Now my brain rewards are getting excited only by my favorable substance, namely tobacco or alcohol. So there is a pathological shift in my hedonic set point in my reward system. And then further dysregulations are happening in the brain reward systems. And then that leads to loss of control over substance intake. Please understand there is a brain mechanism behind substance use. So there are two kinds of people that you can see if you look at people over a period of time. In the initial period, particularly younger people around the age of 20 to 30, these are people who are reward-seeking people. You might see them drinking over weekends, drinking not just like few drinks, drinking bottles and bottles of beer or whiskey, and then they are during Saturday and Sunday they're going to be consuming a lot of alcohol, and that's called binge drinking or binge intoxication. And they get a pleasurable effect, and then once they stay off from it, they have this neutral effect, but they are craving for the reward. Even on a Wednesday, even on a Friday, they're looking at Saturday and Sunday to come so they can go back to it. This is more of a reward craving, and these are people who are drinking in a binge way. Over a period of time, an individual becomes so much like dependent on it. Here, when he does not take alcohol, he's suffering. It is in order to alleviate the suffering, he's taking the drug. So it is a relief craving. So initially there is a reward craving. Towards the end, it's a relief craving. So reward craving and relief craving requires different kind of approaches in terms of treatment. I think it's very, very important for us to understand the brain mechanism behind binge drinking and the compulsive drinking, because the treatment also will become very different for them. And you need to understand the brain behind substance use involves the neurotransmitters. Depending on what drug it is, for nicotine, it is a nicotinic acetylcholine. That's why the drugs are very different. Drugs that act on it are very different. For example, varenicline, acts on this kind of receptors. Ethanol is a very funny drug. Alcohol is a very pervasive drug. It pervades into many transmitters. It affects the GABA, opioids, acetylcholine, serotonin, everything. I think the treatment is also very confusing. That's why we are still a challenge with alcohol. Cannabis acts on a cannabinoid receptor, particularly type 1 receptor. Opioid has very distinct receptors. Mu receptor is the most important one for dependence developing. We don't know the role of kappa and delta. Stimulants are acting primarily through dopamine and also through serotonin. And phencyclidine, ketamine, they all act through these NMDA receptors, and some of them act through sigma receptors. I want to spend some time on this brain behind addiction. This is a very important slide produced by my friend, like Nora Walka, who's the director of NIDA, National Institute of Drug Abuse. And I had the fortune to work with her very closely when I was in Hopkins in the 90s. She's also a psychiatrist, originally from Mexico. In her work on the brain behind addiction, she actually talked about certain areas which are very important. The area in the red, all of you know, it's a subcortical area comprising of the nucleus accumbens and the ventral pallidum. These are where our reward mechanisms are. You and I get the pleasure mainly through this subcortical structures. And then there are these purple structures, namely amygdala and hippocampus, which is very, very important for our emotional learning and emotional memory. This is where all our emotional memory is stored. Everything we remember, I ask you to close your eyes and think about, only negative events will come. That's where everything is registered. So in the hippocampus amygdala region. So I think all drug-related memories are stored here. And then the blue area is the cognitive control, which is the prefrontal cortex and the anterior cingulate cortex. This is the one which is a brake of the brain, which applies the brake. We all know that something is wrong, something should not be done. We are able to apply the brain. You and I are able to apply the brain, mainly because of the anterior cingulate gyrus and prefrontal cortex. And then there is the orbitofrontal cortex, which is the one which motivates us to go for a goal. We all go towards a goal-oriented behavior. Here, drug users are going to a different goal-oriented behavior. Imagine these circuits are completely disturbed. So, simplifying it, because the pleasure circuits are disturbed, my brain tells nothing will give me pleasure excepting alcohol or accepting opium, accepting stimulants, which are my drug choice, whatever my drug choice are. Everything else is secondary to me. I don't get an excitement because my wife is next to me. I have a great food being offered. And then my memories are very strongly stored for drug-related memories. So I can get a cue even after 1 year, and I will stop alcohol for 1 year. I'll come by Pondicherry. I look at a familiar bar, and suddenly I'll go there and start to drink. That's a cue for me to open up my memory towards alcohol. That is where it is stored. The memory circuits are disturbed. And normally, people on dependent pattern of use will know all the harms related to them. You don't have to give a lecture to them. They can give a better lecture on harms than you and I together because they have experienced it. But still, they are unable to stop it. One of the criteria for addictive behavior is inability to stop despite knowing that it is harmful, right? And so there is no point in physician advising them, stop alcohol, your liver is bad, but they will not be able to use it because the brakes are gone here. Lastly, their goal orientation is only towards procuring and obtaining the substance. Please understand the dependent pattern can be very easily explained if you understand the brain behind it. This is a slide of a person who's exposed to a drug. And if you show the drug to the person who has been using a drug, the amygdala gets activated because this is where the memories are. And I think you show them the orbitofrontal cortex, which is the motivated area. Now, suddenly after this, they want to go and search for the drug. So the motivation to go behind the drug is there. So I want to emphasize that substance dependence, substance use disorder is indeed a brain disorder. We are able to understand the brain behind substance dependence. And there are many harms related to substance use. There are physical harms, there are financial harms, social harms. I think our dean really alluded about it very well. There are also some psychological and legal harms associated with drugs. We also looked at people who inject opioids in our own city of Chennai. And this is the work that I've been doing for about, long cohort, about 25 years. I've been following these people. And I think our earlier work was published in 2009, where we saw increased mortality among people who inject drugs. They die prematurely. People who use opioids die prematurely, either of overdose or of HIV/AIDS. Or about, in this now, because of the HIV infection as well as HCV infection, many of them are dying pretty earlier. This is a slide that I took it from Nagaland, where people are injecting pharmaceutical preparations which cannot be injected. They crush in the capsules and inject the dextropropoxyphene, and that has resulted in glorifying abscess in these individuals. And we also know there are certain blood-borne pathogens which are highly prevalent in these individuals. HIV is notably among them. Our group worked in 15 cities across the country, and I think we are able to produce the prevalence as well as incidence of HIV in these groups. Incidence rates are very difficult to obtain. We are the only group to report on HIV incidence in this population. In certain parts of the country, particularly in northern India, in central India, places like Kanpur, the incidence is very high, apart from the very well-known areas of Punjab and northeast India, where everybody knows that the opioid epidemic is very big. But also in central and northern India, this is a huge problem, showing by the high prevalence of HIV and HIV incidence rates in this population. Not just HIV, even hepatitis C is extremely high among this population, and co-infection between HIV and HCV is also extremely common in this part of the people who inject opioids. So I think when we really understand the various harms related to substance use, we might have to take a very simple public health approach. So what is the treatment strategy I would suggest? I would suggest every single physician to be familiar with certain screening instruments, because it's such a common problem. It's very likely that you sit in a OPD, every other person is going to be using, or every fourth person is going to be using some drug or other. So it's very important that you actually screen them. The quick screening is called as a CAGE. So 4 questions you ask them. You ask them, have you been advised to cut down? on any substance, tobacco, alcohol, you can replace it. Have you been advised to cut down on tobacco? Have you been advised to cut down on alcohol? Have you been annoyed if people talk about your substance use? Have you felt guilty about your own substance use? Have you had a substance in the morning? Have you smoked early in the morning or had a drink in the morning on any day? These are 4 questions. If you answer any one of them yes, I think that's a warning question for you to send them for a further assessment. The one that we use for alcohol very often in a medical setting is called Alcohol Use Disorder Identification Test, developed by WHO. It's a 10-item question, a very simple one. It uses something called standard drink. And I give a picture about what is a standard drink. And a standard drink, if you drink about 350 ml of beer, it's about less than 5% alcohol, or about 44 ml of, whiskey, and then that's called a drink. And a woman is allowed to drink maximum 3 units per day, 3 standard drinks a day. You go to a party, if a woman is going to drink, why there is a discrimination? The way alcohol is metabolized in gender is very different. That's why we are not very discriminatory about the gender. We know that the women metabolize alcohol very differently from men, and they are more likely to take into dependence when they drink. So there is a gender variation, which is also biological determinant of dependence. So women, it's 3 units, men, it's 4 units allowed. But on average, you go to a party, anybody will say, you don't go by their largest. Their large is too much of a large. And I think it's a 44 ml is what is defined as a standard drink of a whiskey or a beer or rum or anything. Or if it is a beer, 350 ml is called as a, a unit. So remember, if somebody is going to take on any given day 6 standard drinks, that's a hazardous use straight away. So, and I think for a week, women cannot exceed 14 units and a man cannot exceed 21 units. These are all the safety limits that have been prescribed by WHO. To administer this question, 10 questions, will not take more than 5 minutes in a busy clinic. So if you're looking at a liver unit or looking at a road accident in a casualty, this is a very, very important question that any medical practitioner can give and use it. And from that, you can generate scores. A score of 8 to 14 means the person requires a brief intervention. It doesn't require a state-of-the-art intervention. All he requires is a very brief intervention. This can be done by anybody. A trained medical practitioner can offer this brief intervention. A score is above 15 and above, that's when you have to refer him for a specialist. So people who are below the score of 15, that will be the vast majority of the people. The vast majority of the people can be managed by anybody just by this brief intervention. And also for other drugs, you can easily screen. I think alcohol screening is very popular. I think every police constable is carrying a breath analyzer these days, checking for alcohol. But I think there are other drugs that are also very important. Remember, most of the laboratories today have drug screening tests, urine screening tests. So if you're applying for a job outside the country and they watch through a urine screening, you please be aware that most of the people get rejected because their urine screening detected a particular drug and they quietly said you don't get a visa. And so people do actually urine screening. This is routinely in many other laboratories. So I want to take through this, use an example of heroin and then say how you can provide treatment. Not to imagine there is only one way treatment available for anybody. As I said, a person who has become dependent, you can actually help him through many ways. While all of us agree, abstinence is the best option. You and I will agree that's the best option. If you have to tell substance users, you have to abstain from the particular drug that you're using. That's the best option for you. That's great for the family. That's great for everybody. But it is feasible. Is it doable? If you put 100 people, heroin users on treatment, only 5 people can actually be abstinent over a period of time. That's when US is facing a huge public health crisis of opioid crisis. And we are facing it in Northeast India, Central India, Northern India, and in Northeast India. Because our abstinence-oriented treatment is a big failure, not because it's a bad option. It's a best option, but good, not applicable to only few people. A best option applicable to few people. Whereas what I suggest is a harm reduction principle, which actually is good, but it is applicable to many. In public health, we always don't debate about good and best, right? And we say good is probably better because it's applicable to many. And I would rather choose the good option rather than a best option. If you want to go for the best option, There are many drugs that are available. We can use those drugs. I'll come back to it later. But I certainly believe that people have to really believe in this concept of harm reduction. I believe harm reduction because it's a very practical thing. It's a very pragmatic and a prudent approach. It's a very humane approach because you're respecting the drug user. You are not criminalizing him. You are not marginalizing him just because he's using alcohol or drugs or anything. And I think we are using a significant public health approach. The basic principle behind it is best for few versus good for many. I do not question people who do abstinence-oriented treatment. I only tell them your best option is available only for few. So I will offer a good option that will apply to many. Nicotine replacement, which all of us are familiar with, nicotine gums and replacement, is a way forward, right? That's why government itself is actually accepting that's a way forward. Similarly, I think I've done quite a bit of work originally with regard to opioid substitution therapy in this country, every part of the world, many parts of the countries have done this work. I was impressed on it by this simple slide produced by Dahl, Niswander, and Mary Jean Krieg, a group of psychiatrists and pharmacologists working in New York. They demonstrated by a simple graph. This is the work done 60 years ago, but unfortunately was culled out by NIDA only in 1880s. So 60 years ago, they demonstrated in New York that if you take a drug like heroin, if you can map out what happens in 24 hours, most of the people are in the red zone or in the yellow zone, which means they are either intoxicated or in a state of withdrawal because it's a short-acting drug. I have to take it multiple times. So if I'm a heroin user, I use it 3-4 times a day. So either I'm high or low, high, low, high, low. So I'm not in a green zone at all. What this genius of Dahl and Niswander, along with Mary Jean Krieg, did is to shift the heroin usage to a long-acting opioid called methadone. They did not do a magic work, short-acting heroin to long-acting opioid. If they put them on methadone, the moment they put on a methadone, they grabbed these guys out and they said, we are not in the red zone, they are not in the yellow zone, but they are on opioids, but they are all in the normal phase. So suddenly they said, we can make dysfunctional people to functional people. We can reduce crimes. The police department immediately bought it and started using opioid substitution as a way of decriminalizing New York City. And I think the principle behind opioid substitution therapy or opioid maintenance therapy is we are shifting from an illicit drug like heroin to a prescribed drug like methadone or buprenorphine. We are shifting from an injectable drug like heroin to a non-injectable methadone or non-injectable sublingual buprenorphine. We are shifting from a short-acting drug to a long-acting drug. Everything has a value. You shift from illicit to licit. Suddenly, I'm not a criminal any longer. If I use heroin, I'm called as a criminal. If I use a prescribed drug by Dr. Mahalakshmi, I'm called as a patient. So that makes my behavior also different. You call me a criminal, I behave like a criminal. You call me a patient, I behave like a patient. I'm not injecting, so there is no question of HIV, HCV, and other acquisition. And I'm going from a short-acting to a long-acting, which means I become functional, productive. I can be actually a productive member of the society. So on this, we wrote up a policy paper, and I think we convinced the government of India. Today, we have about 300 odd centers, maybe more centers in the country, which is rolling out, like opioid substitution therapy in this country, thankfully. So I am now working for what we call as a integrated care center. In the same OST clinic, can we integrate many medical services? TB, for example, ART, for example, various things can be put all in one way, rather than the individual going to 5 different places. He just comes to one center and receives all the services because drug users require many, many services. We looked at a cluster randomized trial with these people who inject drugs in 12 sites. So we examined 15 sites, selected 12, randomized them into 2, evaluated them after 2 years. And I think these are the intervention sites of 6 and 6. And what we found, this integrated, co-located models of providing service is quite possible. Simply by arranging different services and then linking them together in one place, we are able to really help the drug user very much. So I really want to conclude by stating that substance use should be not seen as a bad behavior, illicit behavior, criminal behavior. It is better that we understand substance dependence as a chronic, relapsing brain disorder. The attitudinal change in the minds of the medical practitioners is very important because often substance users are the most marginalized ones in any OPD setting. I think don't want to be seen because they feel they are doing it on their own. These are bad people, mad people, sad people, odd people. I want to tell them these are good people with a brain disorder. There are several harms, multiple harms associated with substance use. While pharmacological interventions are extremely essential, some of them can lead to even abstinence. There are also anti-craving medications, which are very helpful to reduce the craving. What is most important when you are approaching substance usage is to have a philosophy of harm reduction. Whether it's a tobacco use, whether it's an alcohol use, or an opioid use, can we actually consider harm reduction as a way of approach to these individuals? It's a question that I want to pose before every medical practitioner. Thank you so much. I'm happy to take questions.
Yeah. Thank you, sir, for that very power-packed speech. And it very nicely you brought out various aspects which related to substance use and abuse. And you started with what is substance, and you moved on to clarifying certain misconceptions about the terminology itself of this thing. Before we take up the questions from the speakers, one thing which came out very clearly, like when we talk to many of the patients, like be it alcoholics who present with cirrhotic liver disease, or be it people who smoke, and you advise them to stop smoking because they have developed a coronary artery disease, etc. And most of the times, what people will say, no, I have control, I can stop whenever I want, I just need this and I can do that. And that part is something I think which you brought out, saying that this is more like and our society or the norms, no? They always ask how your parents have brought you up, or how this sort of behavior is accepted in your setting. That's where our society looks at it, no? So it looks at nurture as a very major phenomenon. In fact, when you are trying to say it is actually something which is happening in the brain, maybe they are predisposed, maybe their behavior is reinforcing their brain circuits. I think that was the defining moment in the lecture for me. And we have some questions. The first one.
I just want to react to your comment about, like people saying, I can do it. I can do it anytime.
Yeah.
Mark Twain once commented, smoking is the easiest habit to give up because I've given it up so many times. So I think what one need to understand, relapse is part of the recovery. Relapse is integral to the addictive behavior. If somebody does not relapse, he probably is not dependent on the substance. Only because he's relapsing, you know that he is dependent on the substance. So it's integral to the definition of addiction itself. Having said that, one must not be judgmental on these individuals. I think one may not judge him just because he's relapsing, because it is no means to say that he lacks in willpower, because it's after all a disease of willpower. When I started this journey 40 years ago, I asked a young man who came to me for smoking, and he came to me for something else. And I was talking about smoking, and I said, why don't you give up smoking? He told me, he laughed at me, and I said, why don't you use your willpower to stop it? I was like a complete naive guy then. He laughed at me and said, he was only 18 years old and I was nearing 30. He told me, Will's power is greater than willpower. Will's is the brand of cigarette. So, and then later on I understood the knowledge that after all, addiction is a disease of will. It breaks the will. So there is no point in asking people to apply the will and the control, which is not there. If the car doesn't have a brake, what is the point in asking the driver to apply the brake? That's what I'm saying. This is the brain without a brake. It's on a fifth gear. It is only going towards one goal of drugs. So understanding this and reflecting this to the client actually makes it a big difference. And they are then with you, right? So this is what the motivational enhancement therapy we all talk about in our treatments. So I thought you said a very important thing. There is a question by Dr. Bhatt which talks about, what is the influence of family on substance use? The family has, we always say, family, from the family, we can understand the child. Often a pediatrician like you will say the child is the biopsy of the family. what happens to the child actually is a reflection of the family pathology or a family dysfunction. If you see a dysfunctional child, often it is reflected back to the family. It's not that we are blaming the family. We can even understand the family pathology from the child's pathology. With regard to substance use, it's rather complicated because, number one, direct contribution comes with genes in terms of a heritability factor. Heritability means I am more likely to develop dependence. Doesn't mean that it's a Mendelian transmission, like, I am a father is an addict, I become an addict. So it's not a significant Mendelian trait transmission. It's a polygenic inheritance, which means I'm more likely to develop dependence if I have a family history. But more importantly, the environment of the family. It is not the presence of family members. It is what kind of a bonding that happened between the parents, what kind of a values and attitudes that they had. Often, substance users come from families which are very enabling in nature, where there is lack of discipline or inconsistent discipline, rather than families which are consistent discipline. So you need to see the difference. There are people who proclaim and say, I'm a very jolly good parent, and I actually allow my son to do anything, and I give him free time. I don't question him. I give him, like so much money to deal with. I give him dispensable money, and I don't monitor him. These are the families from which children are more likely to get into substance use, because I think inconsistent discipline, lack of discipline is a very vital factor. And also, more than broken families, I think that's a very important factor. And I think there is also familial conflict, which can become a stressful factor, because substance use can also be a stress mediating factor. Somehow it gets very entangled with stress mediation. And so a lot of people learn to deal with their stress, mitigate their stress, through alcohol and substances. This is all created by our own social norms. Devadas drinking, you become sad in love, and then you go to a bar and start to drink. There is a kind of image in people that you fail in love, you need to hit the bottle. So these are images built. So similar kinds of things, that stress mediation is also something that's socially learned and biologically, reinforced. So it's a very complicating one. I think rather than offering late intervention, my professor, who's no more, used to say, by the time they come to you, the signs are so badly obvious, sadly, it is irreparable. So early interventions are extremely critical for these individuals. So the moment you identify the problem early on, that's why WHO's approach is very important. It has a public health approach. It's not waiting for people to develop dependence. It's looking for people with hazardous use and harmful use and start to treat them immediately at the primary care level. And if you do that, that's when you can really do so much of a good work in the houses. I think family counseling will become integral to that in that way. Thank you very much for a very brilliant question, Dr. Pat.
Thank you, sir. I think, but sir, you want to react to this answer?
Yeah, I think he has put it in the right way. One thing about, is there any large genetic study or genetic markers among the drug users or abusers? Because
quite a lot of candidate genes have evolved. A lot of them to do with, candidate genes are related to the kind of things. Some of them are to do with aldehyde dehydrogenase. Some of them to do with GABAergic systems. Some of them are due to dopaminergic systems. Even in India, in Delhi, in All India Institute, we've identified dopaminergic genes, polymorphism in people. But these are all genes with small effect. And I think that's a problem. You need to have multiple genes with small effect coming together in tandem to produce any kind of impact. That is where our genome-wide studies are really indicating. There is a lot of overlap between psychiatric disorders and dependence also. People who are prone for certain types of disorders, like say, for example, clinicians will tell that people who have a history of bipolar disorder, for example, or a major depressive disorder, for example, or anxiety disorder, for example, are more likely to have alcohol dependence also as a comorbid, disorder. So maybe there are some common genes which are overlapping between these disorders and this. So at the moment, we all know it's all very helpful in having an heritability estimate, in kind of turning into a public message and saying, if you have a father who's drinking, a brother who's drinking, uncle who's drinking, what's your likelihood? Beyond that, I think we are not able to really intervene at that level. So what we really know at this point in time, one of my postgraduates who's doing PhD in Ramachandra is doing work on opioid polymorphism, new receptor polymorphism, and why some people respond to a drug like naltrexone, for example. Why in some people, when you give naltrexone as an anti-craving medication, it works best. Why in some people it does not work. And so choosing looking at it. So for pharmacogenomics, I think some of these genetic studies also may be very important. So in future, we have a lot of, things that will come up and then inform us, not just for management, for, proper strategies of how you're managing them.
Since you are carrying out many research projects, I was looking in that direction because we have a good psychiatry department. So molecular genetic lab also is available. So I was just coming to thinking in my mind whether I can combine them and put some project on that.
Obviously, because I think at the moment, dependence is not like even though we want to call it as a brain disorder, and I think when you reduce it to a endophenotype level, and I think we have so many things attached to it. So we need to pick on certain endophenotypes and then say, what would be the gene candidate relating to that? I'm sure there is an exciting possibility that we can work together with this department. And I think with some basic science people, genetic people in your department and molecular biology people in the department, I think we have exciting work. I think psychiatrists have to become transdisciplinary, work with other people, learn from others.
Thank you.
So thank you. I think we have time for one more question, which was what other thing which impressed during the presentation was you're talking about an impressionable brain, that the earlier you start abusing before your brain is fully myelinated, the more chances that there is you will fall into this harmful behavior and hazardous behavior and addiction pattern. The thing is, no, sir, like, I do not know. I've been watching how this is being portrayed in the literature, how it is being portrayed in movies and in our everyday life, substance use. See, at least earlier we had the Maco Man, right? The Marlboro Man or the cowboy kind of thing. So you said that you are going to use this and it gives you extra power and stuff like that. But of late, we see more and more of common people, more and more of portrayal of people who are actually like everyday men. But they are the ones they are being shown as getting into alcohol. They are the ones they are shown always drinking or always using substances and things like that. So, is it not making the situation much worse? Like, as a society, is our approach the correct way with regard to this?
You are asking a very critical question. I, for one, very strongly believe the norms surrounding use of the substance is critical in determining how many people will take to a substance. There is an interesting anthropological study that's been done in Kerala. I was intrigued by it because the man goes to argue and say, 30, 40 years ago, in a regular Keralite home, you can't walk in and say, can we have a drink in the evening after day is over? And that would have been unacceptable in most families in Kerala. What has happened after this, 20, 30 years of, money coming in and people becoming more well-to-do and alcohol being more accepted in the society, alcohol use becoming very normative in every community. So just going to a family and then people asking you, including, sophisticated women in the family, put together and saying, okay, you can all have a drink in the evening. I can prepare some food for you. It's a normative change we are talking about. I think while norms change, things also change very dramatically. Not only many people get exposed, and there's more likely that young people are getting exposed to it. I think when the changing norms, increasing availability will also make sure that younger people are going to experiment with that. And particularly when there are no deterrent factors operating in their mind, when it is seen as a stage of experimentation and a curiosity, where it is seen as a matter of pleasure rather than as something which is negatively reinforcing in their mind, they're going to experiment with that. That is where all the problem comes. So I think the best way not to become dependent is not to experiment with anything, right? So I think if you have a large number of people getting exposed and experimenting, then we have a small percentage of them titrating into, like a dependent individual. That is where the problem is. The number of people who are dependent is growing. I'm sure every household will tell, I have a person, somebody in the house who's got alcohol dependence. This is no more a problem that we can close our eyes to. I'm sure I can ask every single person and say, do you know any person who's dependent on alcohol or tobacco? He'll invariably say, I know somebody. For many diseases, they will not be able to say. from their own family, from their own neighborhood, from their own known circles. But I'm for substance dependence. People will tell that the huge harms that is happening to people. That is the change in the norms that has happened over a period of time. And I think this is where I think it's not just the individual responsibility. It becomes everybody's responsibility, including the state responsibility. If alcohol is such a huge problem, and I think we need to understand about the alcohol policy of the state and alcohol policy of this country. When you make alcohol available through government-led outlets, then what do you talk about, and so you're sitting in a city like Pondicherry, and I think you talk about alcohol control. It's like people will laugh at you, right? And then you say, I want to stop alcohol in one hand. And it's really a very difficult debate that we get into. So our approach as a medical personnel should be, okay, I have a public health approach. I'm not getting into the policy debate, but I'm going to offer help to everybody. And I think earlier the better. Early interventions are better. I feel prevention work must be carried out in school by going on telling people, if you tell people do not use, they will become curious to use. If you tell them delay your use, they are more accepting that. I've done that experiment. It's a fine kind of, we are actually interested in the research. We did this, going in school, telling do not use, vis-a-vis delay use. I think delay use seemed to be more powerful a message to people. So I think young people get it more rational, more factual information they want rather than a dramatic influence.
Thank you, sir. I think that was the message which our quite a few students in the audience are there, which they need to take. Like it's not possible to say that one is the right behavior and the other one is say no to drugs, say no to alcohol. Maybe as you say, wait for some more time till you know how to handle them or what it is going to do to your body or it is going to do to your brain. So that is one. And the other message, I think, for the practitioners across all specialties is what you said, no, don't criminalize them, don't marginalize them. They are sad people and they are not bad people, actually. That is something which we need to take. And preventive approaches or promotion of good health should be inbuilt into our practice rather than actually going as a subspecialty, where care is not, should not be a super specialty in medicine, should be integrated. I think that was the two main messages which we take away from this particular lecture. And the other one which I found particularly interesting was this vertical and horizontal integration you talked about. You talk about abuse in all levels. You talk about abuse across various specialties in transdisciplinary fashion. So with that, and I would like to thank Dr. Suresh for a wonderful talk. And sir, you should agree with me that it was worth waiting for 12 years to call you for a stage to this effect and listen to you for your wonderful talk. Thank you very much, sir.
Thank you. Thank you. I'll share the slides with you, ma'am. You can be free to distribute anybody who wanted. Thank you.
And I would like to tell the participants that Dr. Jayakumar, you have raised a hand. Would you like to ask a question?
I want to thank him for giving a wonderful lecture.
Okay. Thank you, sir. And I would like to tell the participants that this video will be available in our YouTube channel. AVMC Puducherry is the name of our YouTube channel. You can go watch it again. And next week, we will actually again come up with another interesting area in public health and one of the emerging areas. That is with regard to organ transplantation. We have a lot of road traffic accidents. We have a lot of people with chronic illnesses who require transplant, but we don't have a sufficient pool of organs which will help these individuals. So how do we actually promote organ transplantation, especially from people who are brain dead considered? So we have Dr. Georgie Abraham, who is the president of the Association of Nephrologists of India, who is also actively involved in the Tanker Foundation for organ transplantation. So he is going to talk to us about organ transplantation, the myths and truths, and what does the law say, and what is the morality and the ethical stand in organ transplantation. So that is the lecture for next week. I hope you will all find time to join us next Friday at 3 p.m. Till then, we'd request all our friends to stay safe and take care of themselves. See you next week. Bye-bye. Thank you, sir. Bye. And this is Dr. Mahalakshmi, Dean Health Professions Education from AVMC, signing off on behalf of the Scientific Forum. Bye, folks.
Bye.
Bye, sir. Thank you.